kind invitation. So today we are going to discuss the treatment approach of diabetes during pregnancy and especially gestational diabetes. Deal with this. These are my conflicts of interests. So the aim is to discuss this treatment approach. I will try to be as practical as possible. It's actually an important issue for three main reasons. The first is that it's very prevalent, with the prevalence of something like 10%. 10% of the pregnancies are complicated by diabetes, which make it most probably the second most prevalent disease during pregnancy, only second to thyroid disease. The second important issue that is it has complications, severe complications, either short-term complications for the mother and the fetus, and especially long-term complication, diabetes type 2 for the mother is there, as well as the famous fetal origin of adult disease, things that may happen in utero that may involve later features in the life of the offspring. And today we have some data even from transgenerational effects, so something that happens in utero and they may affect the following generation through epigenetic mechanism. The third thing, and this is what we are going to discuss today, is we have effective treatments for diabetes during pregnancy, and this is the pyramid of approach that I'd like to discuss with you today. So we will focus on treatment, so I would not take some time to discuss with you what is gestational diabetes. Is of course glucose intolerance, that is hyperglycemia that appears or is first recognized for the first time during pregnancy. And these are the criteria we apply, especially in Europe. As you can see, they are very strict compared to the criteria we have for type 2 diabetes outside pregnancy. So the threshold for fasting plasma glucose goes down to 92, and 60 minutes during an OGTT more than 180, and in 2 hours more than 153. These are the well-known criteria for diabetes, diagnosis of diabetes out of pregnancy. So if a woman fulfills that criteria, most probably she has pre-existing type 2 diabetes and not gestational disease. The pathophysiology is very important. This is the pregnant women and this is the embryo. They are separated but communicated as well through the placenta. So the mother ingests glucose and produces insulin. But during pregnancy, this is apparent in every pregnancy, we have some hormones produced by the placenta that induce insulin resistance. This is something that allows glucose to cross the placenta and go to the embryo. Sometimes this is exacerbated because of genetics or because of environmental reasons. So the insulin resistance gets too much, very increased. As a consequence, the glucose is rising in maternal circulation, and we have an excess of glucose that crosses the placenta and goes through the baby. And this is something that we do not want. Another thing that I'd like to say as an introduction is that insulin resistance is increasing during pregnancy. So if this is the time, this is before pregnancy, first, second, third trimester, this is the delivery time, and this is the puerperium after pregnancy. And this is on the y-axis, the insulin resistance. Insulin resistance is not, it's by definition normal before pregnancy, it's gestational diabetes, and it's not too much during the first trimester. The problems start to begin from the second trimester, where you can see an exponential increase in the insulin resistance that goes along with the exponential increase in the size of the fetus. Usually during the last month, the last 4 weeks, we have a stable situation. And of course, we have a dramatic decrease 5 minutes after delivery when the placenta is delivered as well. So the crucial point during pregnancy is something like from the 24th week, and that's exactly the time that we perform OGTT during pregnancy, up to more or less the 36 weeks. During this period of time, you would expect the insulin needs to increase and increase in a way to compensate insulin resistance. And this is why we perform, as I said, OGTT usually at the 24 to 28 week of pregnancy. The last thing that I would like to say is that we now follow gestational diabetes through a combination of metabolic and obstetrical parameters. Of course, they are well known in this audience, metabolic parameters like the body weight, like the home blood glucose measurements, even the CGM, but of course we have very important obstetrical parameters delivered by the ultrasound. This is the continuous glucose monitoring, but it's equally important to have an assessment of a non-metabolic area, such as the head, the perimeter of the head of the fetus, or even its bitemporal diameter, or even the femoral length, which is very well visible in an ultrasound, and we compare this with the perimeter of the abdomen, which is clearly a metabolic area. So we see the ratio of these two circumference, which is a very important thing. So it seems that in this pregnancy, this is the abdominal circumference, everything go according to the plan. This is a clear case of macrosomia, so we have to intervene. And this is an equally distressful situation with the intrauterine growth retardation. So even if you are in the yellow on the red area, you have to intervene. Something is not going very well. And now going to the actual treatment, how gestational diabetes can be treated. As I said, we have this pyramid starting from its base, from diet, and goes all the way up to addition of rapid insulin. Let's start with diet. Extremely important. I need only one slide to convince you that there is a close association between obesity categories, so class 1, class 2, being overweight, obese, and neonatal death, which the strongest possible outcome in these cases. We know a lot of things about, some things about the optimal weight gain during pregnancy, and today we have to aim for the lower part of the recommendation rather than the highest one. So let's assume a lady that is overweight, BMI between 25 and 29. Our aim is to gain no more than 7 kilos during pregnancy. And as I have already mentioned, if we need a lady to gain, for example, 11 kilos during the whole pregnancy, she may gain only 3 kilos in the diagram until the middle of the pregnancy because of the exponential increase in the second part of the pregnancy. So we have to be rather strict with this lady. On the other hand, there are very many things that we do not know. Okay, we know the overall weight gain, the optimal, but we all want to achieve euglycemia, to avoid ketosis, if possible, to acquire the optimal weight. But what about races? Is it the same for Black ladies or white ladies? What about maternal age? Do we have the same age for a lady of 20 years old as compared to a lady of 48 years old? We have cases like this. What about multiparity, twins or triplets? What's the optimal weight gain? What's the total amount of energy that the woman has to gain? And this is going to be calculated according to the pre-pregnancy BMI or according to her current BMI. Distribution of meal, a lot of questions are still there. Our team in Thessaloniki tried to put together all the evidence about guidelines published by different society about medical nutrition therapy in gestational diabetes. And you can see that there is no consensus. So some authorities, such as American College of Obstetricians and Gynecologists, suggest carbohydrate intake of something like 35%, whether others, the Academy of Nutrition and Dietetics, they actually recommend double the amount of carbohydrates. So there are still a place for consensus there. Physical activity, extremely important. You may say that, okay, the lady isn't pregnant, is pregnant, we cannot do a lot of things, but things are not like this. It's a lot of things that you can do with ladies. And of course, pregnancy is not contraindicated. Exercise is not contraindicated during pregnancy, including swimming. Why not? There are a lot of contraindications, as you can see in this busy slide, but on the other hand, fortunately enough, the majority of women do not have this contraindication, so there is absolutely no reason why not to exercise themselves. Of course, exercise is medicine. As in every medication, you have to prescribe it. So we have prescription principles such as the fit. You have to prescribe the frequency. So how often? Every 2 days, every day. About the intensity. What about the intensity of an exercise? What about the time? 30 minutes, 15 minutes, 45 minutes? And the type. Is yoga and aerobic exercise have the same effect on hair? Once again, our team tried to put together all the guidelines about physical exercise during pregnancy. Things are better here compared to diet. The majority of the authorities suggest that we can go up to 150 beats per minute concerning the intensity of the exercise. Have in mind that a woman has a baseline heart rate of something like 100 during pregnancy, and that the best thing you can do is to advise her to exercise 3 or 4 times a week, 45-minute sessions seem ideal with 5 minutes break every 15 minutes. So exercise. Anti-diabetic medication. In Europe, it's almost uniquely metformin. We do not use it very much. And this is not because that it's not efficient or it's not safe. Of course, it's crossing the placenta. It's that we are going to use it anyway, if there is a need to use it, just for a few weeks. If we have the diagnosis of diabetes in the 28th week, we see the women for the first time in the 30th week, and she's going to deliver in 38 weeks. So anyway, it's a very small amount of time, something like 8 weeks or 10 weeks. So usually there is not much debate about using metformin. In a type 2 diabetes, a patient may be in metformin for years before we have to advance its approach, its therapeutic approach. But this is not the case here. That's why, if there is a need, that in our heads, this happens in about 1/3 to 1/4 of the ladies. So diet and physical activity is not enough, and we have to add basal insulin. All the usual questions about starting insulin, they are there. And once again, think of what we have discussed. In order to decide if it is time to start insulin or not, please consider as a combination both metabolic and obstetrical parameters. So I'm going to do different things if I have a good metabolic control, but the abdominal circumference is out of the threshold, and different things if the metabolic control is not very well, but on the other hand, all the fetal parameters are within reference range. So you have to put this into combination. Of course, you can use insulin detamir. There are specific studies, more than 10 years now. Ellen Mathieson showed that it's equally effective to the classic insulins and pH, so you can use it with a little bit of hypoglycemia, a little bit of less hypoglycemia, and usually hypoglycemia is not a real problem. It's not a problem at all, I would say, if you use basal insulin in women during pregnancy. There are no studies of equal evidence concerning insulin glargine, but anyway, you can use it during pregnancy. If a lady with pre-existing diabetes, either type 1 or type 2, is already on insulin glargine, you can continue treat her with this. And very soon, I think in a couple of months, we are going to have the publication where part of this study that insulin deglutec can be used as well in pregnancy. So there was a specific study, and insulin deglutec can be used in insulin. Our last weapon is rapid insulin. If there is a need, if you have postprandial hyperglycemia and you have to confront it, then of course you have to add rapid insulin before the meals, and you can do it either with Lispro or aspart insulin. They do not cross into placenta. This is true for all type of insulin, and they are safe therapeutic options. So this is the treatment pyramid. My aim today was to discuss with you the treatment approach in women with gestational diabetes and be practical. If you want more information, combination of Greek endocrinologist and fetal maternal specialist provided these very recent guidelines. The previous year was published in Hormones, the journal of the Hellenic Endocrine Society. So it's there. You're going to find many information, practical information there concerning either pre-existing diabetes or diabetics during pregnancy. These are the links in English and in Greek. And many other things are discussed there. What's the risk factors for adverse outcome in these ladies, and what's the optimal time of delivery in these women? Saying just one word, we can go up to 40 weeks. There is absolutely no reason to deliver this lady at 38 weeks, which is the usual approach sometimes, and what to do even after delivery. And finally, I'm lucky enough to publish this very recent book. It came along something a couple of weeks ago. So it's a comprehensive clinical approach to diabetic during pregnancy, both pre-existing diabetes and diabetics during pregnancy. So a lot of science all over the world, including Panagiotis that I have in front of me now, contributed to this very new book. With this word, Thessaloniki is very, very near to us. Professor Kotsis, Vasilis, I'd like to thank you very much for this kind invitation. Thank you very much for your kind attention.
I would like to thank you.